Okay, so I'm going to talk about my daughter. This is her last journey. She had a number of hospitalizations throughout her life. This was her last journey in the hospital before she passed away. This is a subject I'm very passionate about because she was the most important person in my life. I'm going to focus on the things that I was upset about because those are the things that we can learn from and make things better for the next patient. But just know that there was a lot of good that was done. There were some amazing people that took care of her, but just one mistake can kill, just one. So who was she? And you'll get an idea from the video. She was my daughter. She was born premature at 24 weeks, now 40 weeks is term, so she was 4 months premature. And because of the complications of prematurity, she had bleeding in her brain, and she ended up with cerebral palsy and was wheelchair bound. She was very smart, funny, she was full of joy. She just had this magical way of lifting others up just by being around her. She was really pretty amazing. Her favorite subjects in school were literature and science. She loved thrill rides, not me because I have motion sickness. But she went parasailing, indoor skydiving, swimming, horseback riding. She loved books. She loved her lipstick and her necklaces. Couldn't be seen without them. She left behind a boyfriend, Jose, and her best friend, Kelsey, and she was my hero. So she did have some medical issues in her life. Volume okay?
Yeah.
Okay.
I think everybody can hear, right? Yeah.
Okay. So as a newborn, she had bleeding in her brain. It's a complication that sometimes happens with extremely premature babies. And it was from her extreme prematurity, and she was also a twin, and she had complications with her twin. She had a shunt placed. So a shunt is a little tubing that goes from, in her case, from her head to her belly. Her body did not, was not able to drain the spinal fluid, so she needed a shunt to be able to do that. And she had numerous shunt revisions the first 3 years of her life, and then she, at age 3, she went to Shands, saw a renowned neurosurgeon, and that fixed her for a long time. And she was seen by a number of other subspecialists, but she was doing very well. So I'm going to go over the timeline of just the first month of her hospitalization. And then I'm going to go into different areas that were problems for her. So the journey started Saturday night of Thanksgiving weekend in 2019. Paige was 23 years old. She weighed 84 pounds. She was home in bed, and she was having a seizure. Now, seizures, she had a seizure disorder, but they really weren't a problem for her. But we had to call paramedics. They came to the house and they said, well, she has to go to the adult hospital because of her age. Well, she had never been in the adult hospital. We had absolutely no idea it made a difference, but I learned that it did. And so she was in the emergency department overnight, and she had imaging, and it showed that there was bleeding in her brain. And she was placed on a ventilator, but she was off by Monday. And she had an external shunt because the internal one wasn't working. It's called an EVD, and external ventricular drain. And it went from her head to a pump, and it needs to clear all the blood that's in the CSF before they can put in the internal shunt, or the internal shunt wouldn't work. So that's just a waiting game. So we're waiting for her surgery, which happened on December 16th. Hematology did come in, and they were consulted. They diagnosed a mild bleeding problem, and they said she needed fresh frozen plasma before surgery, and then she's fine. So after surgery, she was never okay. The surgeons came in and said, oh, it went well, but she was never okay. Monday was her surgery. Wednesday of that week, she was transferred to the regular floor in hopes that we can get ready to go home by Christmas. And, but she was just never okay. By Friday, they came in, they adjusted the pressures on her shunt valve. She was still never okay. So Christmas Eve day, I was still hoping she could somehow go home by some miracle, but she ended up spiking a temp of 102.8. So this is 8 days after surgery. So to me, the most logical explanation was an infection from surgery. And so I asked in the morning, I asked for the neurosurgeons to come in. They never came. I waited all day. I kept asking. Never came in. Now remember, it's Christmas Eve. Nobody wants to work. They never came in. They finally came in the evening. They refused to examine her. They said she was fine, and they said they signed off on the case. They refused her. The refusal of care would never have happened in pediatrics. The refusal of care started the downward spiral leading to her death. They flat out refused to take care of my daughter. That was their patient. She had a temp, and I was watching her in incredible pain with a temp. And I saw nothing being done to help the pain or the temp. And it was very distressing to me. So I thought, what would I do at home? If I was at home, I'd give her Motrin, I'd give her Tylenol, and I'd put her in a cool bath. Well, I can't do any of those things in the hospital. So I went and I asked for ice packs. I can ask for ice packs. So they said, oh, well, she can have a cooling blanket. Well, they should have offered a cooling blanket. I shouldn't have had to ask to take care of my daughter properly. And I talked to a nurse leader during this time, and I said, I feel like I'm watching her die. She became very defensive. She said they were doing everything they could. I didn't see how that was, they were doing everything they could. When,
I'm sorry, how high was her temperature?
her temperature was 102.8 on Christmas Eve day. By Christmas morning, it was 103.6. It had gone up. And so the most logical thing to me was an infection from surgery. And remember, an infection can cause the temp can cause the fever. Can cause a seizure, which happened a few days later. So on Christmas morning, remember neurosurgery refused to see her. Christmas morning, they consulted infectious disease doc. He came in the morning, and he said, I think it's her shunt. And I said, I agree. Can you reconsult neurosurgery? Because they signed off on the case and they refused to see her. And they never came in. So the plan was also to get interventional radiology to get a sampling of her spinal CSF, or cerebral spinal fluid, so they could culture it to see if there was an infection and to start her on the appropriate antibiotics. Well, this is Christmas Day, remember, they never saw her, they never got a sampling, and they started her antibiotics without having a clue what they were treating. So they couldn't treat her properly because they didn't know what they were treating. So because neurosurgery said, oh, it's not us, not us, the team was trying to blame something else. Well, I worked in the NICU for 39 years. I have a lot of friends that are physicians, and they were calling me and giving advice. One in particular was contacting me almost every day. So I ran a lot of stuff by him, and they were trying to find other causes. So one of them was pulmonary embolism. He said, Linda, it's not a pulmonary embolism. Pulmonary embolism does not present with a fever. It presents with shortness of breath and tachycardia. It wasn't pulmonary. So then they said, well, maybe it's your gallbladder. He said, Linda, it's not a gallbladder. He explained why, and he also said that he's worked with other physicians that have blamed gallbladder when it's been a shunt issue. Wasn't her gallbladder, but the team did not drop it, and that complicated things even more. So Christmas was Wednesday. By Friday, even though neurosurgery refused to see her, they pushed the issue, Paige pushed the issue by having a horrific, life-threatening seizure. It's called status epilepticus, and you seize and seize and seize and seize and seize, which is what she did. And so I was standing at the bedside, and there was this very nice male nurse, and he was experienced, he was training somebody. So he was at the bedside, and I said, she's having a seizure. And he was very calm and said, oh, what do you do for a seizure at home? Do you give her oxygen? Well, first of all, she didn't have seizures like this at home. Second, my daughter was having a life-threatening medical emergency as we were talking, and he was doing nothing. I said, you need to call Dr. Tamo, you need to give her Ativan, and you need to call the rapid response team. So he did. Now, I should not have had to tell him how to handle my daughter's medical emergency, life-threatening medical emergency. So the rapid response team came in and it was headed by our chief of critical care, who's absolutely phenomenal, absolutely fabulous. So thank goodness it was him, because I think she would have died that day if it weren't him on the team. He transferred her back to the neuro ICU, and I had to wait until they allowed me to go see her. So there was a nurse practitioner that came, got me sweet as could be. And when I was allowed to see her, she brought me down the hall and said, "Linda, we know what's wrong with her now. It's her shunt." And I looked at her and I said, "I know." But the team would listen. So after the 27th, it became pretty complicated, but the biggest issues were pain management and respiratory. So I'm going to zero in on a few different areas. The first I knew nothing about, that there is a breakdown between peds and adult care. I had absolutely no idea until this experience with Paige. And I learned that Baylor actually has a conference on this issue that they've had for over 20 years. Because it was during COVID, I was able to attend virtually, and I was blown away by this conference, the content, and the fact that this has been a problem all over. So, like I said, neurosurgery refused to see her. Not the same as the pediatric model. The pediatric model, they will see you and see you and see you as long as you're still pediatric age forever. I mean, as long as you're still pediatric age. The adult model, surgery, go on to the next patient, surgery, go on to the next patient. And another issue was she was vented after she had that massive seizure. She was ballistic with the endotracheal tube. Every second she was awake, she was absolutely ballistic. And the tube was not secured properly. And I thought, I worked in the NICU at the time. And I thought, if we can secure an ET tube for a baby that weighs less than 1 pound, why can't we secure an ET tube properly for my 84-pound daughter? Now remember, we're in the adult world, and she's not adult size. She was a pediatric size, even though she was an adult. So I thought, well, maybe they can call the peds team. I mean, we have all the supplies in the corporation. All they have to do is call and just talk to somebody with the peds team. Well, they didn't. One person was able to take the tube appropriately so that she was a little bit more comfortable. But most of the time, she was absolutely miserable and it wasn't secured properly. Use your resources. It's a strength to ask for help. It's a strength to use your resources when you need them. It is not a shortcoming. And hospitals can be, especially ICUs, can be territorial, and just know that you're doing the right thing if you ask for resources when you need to. The other thing I did is I have some very close friends that are respiratory therapists. I'm not. And I thought, well, maybe they can give me some advice to get her off this vent, or at least off the ET tube. In the baby world, for some babies that are eligible, we have something called NIV-NAVA. And they don't need an endotracheal tube, it's just a cannula. And I thought, well, maybe there's something in the adult world. So one of my friends suggested OptiFlow, which she got, and it was a huge help. And the other thing that was a help, she had a critical care doc. I talked to her around New Year's, and she said, "Linda, I'm on service for 4 days. I'll get her off the vent before I sign off." So, the chief of critical care, who I said was so fabulous, he talked to me after the event happened where neurosurgery refused her, and he apologized to me. He said they're going to have a debriefing. That's what they do when things go wrong. And then he told me to call the pediatric intensivist, who was a very close friend of his. I'd known this intensivist as long as I've been working in a hospital. So I called her, and she actually had an initiative to bridge that gap between pediatric and adult services. And she said, "Linda, Paige was not the first patient to lose her life going from pediatric to adult care." And she's the one that told me about the Baylor conference. Another issue was pain management. Paige was, when she first was admitted, she was pretty comfortable. And then she had the surgery on December 16th. And then she was in incredible pain, which was very unlike previous experiences of surgery with her. Even the most minimal movement of her head caused her extreme pain. And this is a kid with very high tolerance to pain. And she couldn't, because moving her head a microscopic amount caused too much pain. She couldn't eat because that caused pain. And then she couldn't absorb her medicine because it was just too painful. So after surgery, there was an event. They were going to pull the external shunt because they had already replaced the internal one and they didn't need the external one. And they were going to pull it. And I said, can you please give her medication for procedural pain? Well, they refused me. So they took the tube, they pulled it out of her head without giving her anything for pain management. And she immediately had a seizure, which did not surprise me at all. Then, because pain was such an issue, one of the advanced practice clinicians in the ICU suggested consulting a pain management doc. And I thought that's a great idea. So a few days later, when pain wasn't managed, I didn't see a pain management doc. I asked about it, and she said, well, Paige couldn't have a pain management doc. The pain management doc was only for cancer patients. And I thought, this is an excellent, large, level 1 trauma center. And my daughter cannot have a pain management doc because she is not an oncology patient. It made no sense to me. I contacted my administrator and I contacted the hospital administrator, the hospital president. I knew both of them because I worked there. And they cared, but it didn't solve any problem. It didn't help. And towards the end, I requested palliative care because pain management does fall into the scope of practice for palliative care. Infection prevention. Remember that infections can kill. In the NICU, never ever would I touch a doorknob and touch a patient without washing my hands because infections can kill. I could pass an infection on to them. So I'm kind of hardwired for infection prevention. I saw poor practices among everybody. One, I'm going to share just a few things with you. One situation, Paige was getting ready to go to surgery. The hospital has a very strict policy or protocol for preventing hospital-acquired infections. The nurse thought she was going to go to surgery. They followed the protocol. Paige was bathed. The bed was clean. Everything was according to the strict protocol. The nurse dropped her medication on the floor and picked it up off the dirty floor without putting it in anything else, a plastic bag or something. She put it right on the bed to go to the OR and just contaminated everything. There was another experience. There was an advanced practice nurse that was doing a bedside procedure that was a sterile procedure. She dropped all the packaging on the floor. That's fine, that's what's done. Then she went and picked it up all off the floor and put it in the trash, that's fine. But then she went to reach for my daughter with her dirty gloves. And I said, not until you change your gloves. There was an RT that came to give her a treatment. And she had her computer with her. And she went from the computer to my daughter, to the computer to my daughter, the whole time she was doing her treatment. That's what she did. Then she took that computer without cleaning it, went to the next patient, and got my daughter's germs. On the next patient, she did the same thing to my daughter. So I talked to a very close friend of mine who's an RT. She said, Linda, you know why she did that? She did that because her caseload was too high. I said, you always do the right thing. It may take you 30 seconds to get a glove, put it on, and wipe the keyboard before and after each patient. I understand that you don't want to be fired, but in my opinion, if you're fired for something like that, then you'll find something better. There was a newer nurse that had her a number of times, a very nice man. One day in particular, he had very poor infection prevention practices. And I told him, And he thanked me. And that is so rare because most people get very defensive. There are ways to communicate in a kind and compassionate way. Which brings us to communication. So this was a bizarre situation that I can't believe happened. So remember, we were on Saturday night of Thanksgiving weekend, we were in the emergency department all night, got no sleep. Early Sunday morning, she was admitted to neuro ICU. And when they allowed us to see her, my husband and I were in the door frame of the room. We hadn't even gone in the room yet. There were two nurses in the room. One of them very rudely said, "You cannot bring any food in here." Well, first of all, we didn't have food. Number two, we hadn't had any sleep since Friday night. This is Sunday morning. I could care less about food. All I cared about was my daughter and sleep. But there are kind ways, and the nurses, there were a lot of situations that the nurses did not treat my husband kindly. When you're talking with the patient, you're going to have to say things that maybe you don't want to say. Or say you're that RT that you have too many patients. But this one particular patient, they've never had treatment before. So you need to just explain them for a second. You have a choice. You can stand up, you can sit down. Well, the research has shown that if you sit, it doesn't take any longer than if you stand. And if you sit, the patient is going to perceive you more positively than if you stand. So I would recommend highly that you get in the practice of sitting, even if it's just for 30 seconds. You're going to have to communicate with patients that are hard to communicate with. When Paige couldn't talk, I had her squeeze my hand or I had her do various gestures. Some hospitals had language boards. I used to use the language line for like an Arabic patient. The other issue that happened was team communication. So Paige was still followed as an outpatient by pediatric neurology. And he was part of the peds team, but he came to the adult ICU to see her many times. The team called him to ask a medication question during the time she was having that massive seizure. They never told him she was having a seizure. That was beyond my comprehension, how you could talk to her neurologist and not tell him that. It was just beyond my comprehension. So in closing, remember, asking for help is a strength. You can communicate difficult things with kindness. Always do the right thing. There were many times during my career that I just kept saying, you do the right thing anyway. You do the right thing anyway. And thank you for your time.